we're talking a lot about hormones, and these patients can present with a variety of different syndromes. Carcinoid patients present with flushing and diarrhea. Patients with pancreatic neuroendocrine tumors have a whole constellation of symptoms. Diane, do you test different hormone levels for these patients when they come into the clinic?
That's a great question. So as I alluded to before, in pancreatic neuroendocrine tumors, often if they're hormone secreting, they will have obvious clinical symptoms that will warrant further workup, and you can allow your hormones to sort of drive the management in that circumstance. So for example, if they have low sugars, you don't need to do a glucagon. So I think you could be a little bit thoughtful on the hormone workups in a pancreatic neuroendocrine tumor, which most commonly is non-functional. In patients with carcinoid of the midgut, I generally do a baseline urinary 5-HIAA when I first meet them. For two reasons. One, I just want to make sure that their baseline is normal if they don't have any hormone secreting symptoms. Certainly, if they do, then we would most certainly do that. But we're actually noticing that over time, these hormones from the carcinoid syndrome can be quite high in terms of the morbidity that they may have. So what I mean by that is, for example, carcinoid heart. Many of our patients, thank heavens, are living for many, many years now. And that's because of supportive measures that we have and better imaging and the multidisciplinary team approach that we're taking. But over time, these hormones can really cause damage to the valves of the heart, and having a valve replacement is obviously quite risky with high morbidity. So you want to be aware. It can also cause other troubles with mesenteric problems and fibrosis. So it's a hormone that you don't want to miss. And I generally just do 24-hour 5-HIAA. I don't do any additional hormones.
You make an interesting point. We were talking about surgery, but these patients can get valve disease, which may require valve replacement. And Eric, I imagine you probably want to get echocardiograms on some of these patients before you operate, just to check.
Absolutely, exactly correct. And I too order a 5-HIAA also because it seems to be a predictor of those who are going to have carcinoid heart disease. And so that gives me kind of a sense, even if I get a baseline echo at this point, they may not have any issues with their heart now. It may progress, so I may want to watch it more carefully. The one thing I do want to add, though, is that since carcinoid heart disease isn't so common, thankfully, unfortunately, when it does strike, you want to treat it earlier rather than later. So by getting an echo and following them with time, you can see when is the right time to repair them. Because when someone is healthy and strong, it's actually a very safe and extremely effective therapy. But when they're very, very ill and emaciated and it's late in the course, doing a heart operation is much more complicated and has many more complications associated with it. So we always want to make sure we stay ahead of the game rather than falling behind.
I guess in the best of all possible worlds, we'd be able to shut down the hormone secretion and not have these complications. Let me turn to Jennifer. There have been a variety of drugs that are used to control symptoms of hormone hypersecretion. The first, I think, was Octreotide. How do you use Octreotide in your practice?
So typically, for patients who do have hormone-producing tumors and are symptomatic from those hormones, Octreotide has been our sort of go-to therapy for several years now as the frontline standard of care to try and keep those hormone levels low and decrease the symptoms associated with both carcinoid syndrome and symptoms from pancreatic neuroendocrine tumors that produce hormones. I also tend to, if patients develop refractory symptoms with Octreotide use, we do oftentimes raise the dose of Octreotide in an effort to try and further control their symptoms.
And another approach that's been discussed is that sometimes people use so-called rescue medication or injections of short-acting Octreotide as well. Do you send patients home with short-acting injections too sometimes?
Right, I do, especially for patients who are capable of administering those medications to themselves. I think that's something that you definitely have to take into consideration when you tell patients, that that's a way that we can potentially manage their symptoms. So an alternative would be a higher dose of depot injection to maybe prevent them from having to give those self-administered injections. But definitely, because it's not always clear, patients have episodes that occur in their lives, stress or dietary issues or what have you, that can result in a surge of hormone production. And so having those rescue injections at home can be very helpful.
I would just add some supportive medications too. So, you know, a patient has diarrhea, Imodium works beautifully, you know, so we can't forget
Right.
like the common things in medicine that are very helpful.
Absolutely.
A little Lamodal can really help.
Right.
So now that there's another somatostatin analog, lanreotide, and we've all heard about lanreotide, and we'll talk about lanreotide for tumor control, but it's also been used for a while, I think, for symptom control. Eric, do you want to enlighten us on lanreotide and how it might fit into symptom control for these
absolutely.
patients?
So lanreotide is a sister, it's another somatostatin analog to our good friend octreotide. And as you had said, it's most exciting recently because of its use for tumor control. But because of it's a somatostatin analog, it still has effects on controlling symptoms. And so there was a trial that came out, the ELECT trial, which was looking at the control of carcinoid syndrome symptoms. And it was found a little bit in a slightly different type of trial than compared to octreotide, which got its original approval. It was shown to certainly help improve some of the symptoms too. So it's good to know that our two somatostatin analogs are effective with tumor control and for symptom control.
We were talking a little bit about the way that some patients might be on these somatostatin analogs for months or even years, but they do get breakthrough symptoms sometimes. Imodium or Lamodal are great in some cases, but don't always completely do the trick. Let me turn to James. There's a new drug, Telotrestat, which is a tryptophan hydroxylase inhibitor. What do we know about Telotrestat in this setting?
Well, Matt, as you know, tryptophan hydroxylase involving serotonin synthesis, and there's still a really a unmet need for patients with refractory carcinoid syndrome. And given that its role in serotonin synthesis, there's rationale that this drug may be very helpful in patients with, poorly controlled diarrhea. And recently, a large phase 3 study was completed, TELESTAR study, and we're very fortunate to have the PI here. And so, Dr. Kulke?
Take it away.
No, thank you. So the TELESTAR study was an interesting study. So it was a randomized study. It took patients who had carcinoid syndrome and had diarrhea that was refractory to standard dose somatostatin analogs, and randomized them to receive either treatment with Telotrestat or treatment with placebo. And the results were really quite interesting. There was a significant decrease in diarrhea in the patients who received Telotrestat. There was also quite a dramatic decrease in 5-HIA, which suggests that it really is inhibiting serotonin synthesis. And we were talking earlier, I know with Eric, about carcinoid heart and some of these other complications of serotonin. So I think it'll be really interesting to see what role this might play down the road.
Absolutely.